Some journeys aren't defined by a destination, but by their transformation. From passionate beginnings to defining milestones, the Pakistan Cardiac Super League became the heartbeat of academic excellence. Two pioneers joined forces once again to ignite the spirit of learning and leadership. What began as a challenge became a movement. In every round, a new hero emerged. In every team, a story was written. Now, the legacy continues as 16 elite teams step into the arena to prove their strength, their skill, and their synergy. Team LNH Pelicans, Team SGTH Tigers, Team BVH Cardinals, Team FIC Fighters, Team SICVD Thunders, Team AFIC Lions, Team PIC Hawks, Team Dow Dolphins, Team NIC VD, Team RIC Dreadnoughts, Team Looms Falcons, Team MIC Panthers, Team AKUH Stars, Team BMC Strikers, Team HMC Stallions, Team PIC Warriors. Guided by the visionary stakeholders of the Pakistan Cardiac Society, steered by the Governing Council, the backbone of PCSL. Judged with fairness and integrity by our panel of expert umpires, and held together by the voice of reason and brilliance, Dr. 𝐏𝐚𝐤𝐢𝐬𝐭𝐚𝐧 our moderator, whose pivotal presence made this league a resounding success. Glory goes beyond borders. The winning team will earn a prestigious opportunity to participate in an international cardiology event. Mark your calendars, the battle for brilliance begins August 9th. Pakistan Cardiac Super League, Season 3, the ultimate test of knowledge. Powered by Wilson's Pharmaceuticals.
Assalamu alaikum and welcome. I'm Syed Hamza Hussain. It's an honor and privilege for me to be here with you for the fourth match of Pakistan Cardiac Super League Season 3, which is going to be played between two teams from Group D, AKUH Stars and HMC Stallions. This event, as always, is a proud collaboration between Pakistan Cardiac Society and Wilson's Pharmaceuticals. Before diving into the match, I would like to introduce and welcome the esteemed council members and umpires of today's match. We have with us the match umpire, Professor Mohammad Ishaq Saab. We have also with us the program chairperson, Professor Feroz Mehman Saab. And we have also with us Professor Hafizullah, Professor Fawad Farooq, Professor Ambar Ashif Sahiba and Professor Abdul Hamid Siddiqui Saab. Last but not the least, I would like to introduce the voice of Pakistan Cardiac Super League Season 3, Dr. 𝐏𝐚𝐤𝐢𝐬𝐭𝐚𝐧, and I will request Dr. 𝐏𝐚𝐤𝐢𝐬𝐭𝐚𝐧 Saab to please start the official proceeding of today's match.
So thank you very much, Hamza. So back again with another match, and first of all I'd like to take this opportunity to welcome you all to this third season of Pakistan Cardiac Super League, which is brought to you by Wilson's Pharmaceutical in collaboration with Pakistan Cardiac Society. Well, we all know that every match is extremely important, as each and every one of these matches is going to be a knockout game. And we've had some wonderful games so far. So today, again, we have two very important teams which are there in front of us, and we have Hayatabad Medical Complex Stallions going up against Aga Khan University Hospital Stars. So let's see where we end up. But before we move on, I'd like to take this opportunity again to welcome our esteemed faculty members, our panel of experts for the game today. And we have amongst us Professor Feroz Mehman Saab. So welcome. It's great to have you. And we also have with us the mentor of HMC Stallions, and that is Associate Professor Asghar Khan Saab. Great to have you, sir, and best of luck to your team. Last but definitely not the least, it's the umpires who are so very important for the games. And it's Professor Ishaq Saab, Mohammad Ishaq Saab, who's always there. He's there to support all the matches, all the leagues, and he's such an inspiration. So welcome, sir. It's great to have you all today for this game. And with this, we are now going to move towards the two teams. And I'm going to randomly move towards one of the teams, HMC Stallions. Can we have the introductions? And I'll ask the captains to give us the introduction of their members.
Assalamu alaikum. I'm Dr. Kamran representing HMC Stallions and along with
Hamza, kindly increase the volume.
Right, sir. So
Volume
can you
can't have
increase
all.
the volume, please?
I can't hear you.
Technical team, I think you need to look into this. Ishaq Saab is unable to hear us. Okay, team, can you hear me clearly?
Yes,
The two teams?
No, I can't hear the team, you see.
Okay, sir, they are looking into it. So technical team, I think you will have to.
I am Dr. Kamran representing HMC Stallions along with my team members Dr. Zubair, Dr. Yamna and Dr. Mariam.
All right, so I think you will have to keep the mic closer to you when you speak, but I think I could hear you. So welcome to the game. I hope you're all prepared for it. Best of luck, Stallions.
Thank you. Thank you.
Okay. So can we have the stars? Aga Khan, stars. Okay. Seems like a pretty
Assalamu alaikum everyone.
gloomy
My name
picture.
is Dr. Hassan Mahmood. I am the captain of AKUH Stars.
Okay.
And here with me is my team member Dr. Aisha Mehman. Our two members are currently on the way due to transport issue, but we'll be proceeding with the case. Thank
So
you.
I hope they'll be there with you soon because you'll be needing them. In any case, I think we have to move on and start the game. So, all right. So with the introductions, best of luck to both of you, to the Stallions and to the Stars. Okay, and what's the weather like? Seems like a bright day. Sun is shining bright. The pitch looks beautiful. I think it's going to be a high-scoring game. And we all enjoy seeing all the sixes. Okay, with this we now move to the all-important coin toss, which is going to be done electronically. So can we have it on the screen? And I'm going to randomly ask one of the teams. I see Aga Khan on the screen. So, what do you want, heads or tails? Aga Khan, stars. I think we've lost them, so I think I'll move to the Stallions. Stallions, you're there. What do you want?
I would like to go for heads.
Okay, heads is the call. Roll the coin, please. And it's a tail. Oh, never mind, you've lost the toss. That's all right. But I think the good thing is definitely for the Stallions that, in fact, for Aga Khan, that they won the toss, but we don't have them on the screen yet. We've lost the connection. So the technical team is looking into it. Can we have them on the screen? Okay, so the team is still on it. They are trying to get them back. So Stallions, you never really mind because you see, it's your luck. You lose the toss, but you never know. It's like any other game. Even in cricket matches, we lose the toss at times, but then again, the luck may still favor us. So I see Aga Khan. They are back. Can you hear me?
Yes, we can hear you.
Okay, so there's good news for you because Stallions had called heads on the toss, and so they've lost and you've won. So I'm going to pose you with two questions as per the format. The first one is, you want to throw the questions or you want to take the questions?
So we'll toss to them. So we would like to toss to them.
Okay, you want to
We'll
throw
toss the question to them.
Okay, so you want to
Yes.
ask the questions. That's what you've decided. And now we come to the second question. So we have two scenarios on the screen, case A and case B. Which case do you want to pick as you have decided to ask the questions?
Case B.
Okay, so you've picked case B. The news from the center is it is Aga Khan Stars that have actually won the toss, and they've decided to throw the questions, and they have picked up case B. So best of luck to both the teams, and I'll ask our umpire, Professor Ishaq Saab, sir, do we have the permission to start the game?
Yes, please, go ahead.
Thank you, sir. Okay then, can we have the scenario case B on the screen, please? And I'll request the stars to read the scenario, please. So, Aga Khan, you'll have to unmute and you'll have to read the question, since you are throwing the question.
Okay. So, case B is of an 81-year-old woman with CKD eGFR of 25 ml per minute, permanent atrial fibrillation, taking apixaban, prior history of GI bleed and severe mitral annular calcification.
Just hold on. So you can't see it, Stallions?
अभी display हो गया case.
Okay, so you have to pin it. I think you can see it now, right?
Yes.
Okay,
Yes.
go ahead, please.
Taking
Stars.
apixaban,
Whenever they start talking.
we can't, we are unable to
You
see
have
the
to pin
question,
the screen,
please.
Stallions. You have to pin it.
Okay, can you move the वो talking वाला move कर हाँ जैसे ही है.
Okay, everything good?
अभी ठीक हो गया अभी डिस्प्ले पे है लेकिन जब से ये रीड करना स्टार्ट कर लेते
So अगर आप पिन कर देंगे तो वो मूव नहीं करेगा. Okay, so आप उसको पिन करवाएं. Technical
Okay,
team,
now I
I think
can
you
see.
need to help them. Yeah. So start, please.
So 81-year-old woman with CKD, eGFR of 25, with permanent atrial fibrillation, taking apixaban, prior gastrointestinal bleed and severe mitral annular calcification, presents with New York Heart Association class 3 dyspnea. Transthoracic echo demonstrate heavy MAC with an irregular non-circular orifice such that planimetry is unreliable. The mean transmitral gradient is 9 mm mercury at a heart rate of 70 beats per minute. The left atrium is markedly dilated and the mitral valve area is estimated at approximately 1.4 centimeters square. There is no commissural fusion. The heart team considers her prohibitive risk, surgical risk, and deems her inoperable. Cardiac CT shows bulky annular calcium extending toward the left ventricular outflow tract.
All right, so Stallions, you have a few seconds to gather yourselves, and then we will start with the question number 1.
बल्कि कैल्शियम severe MS second markedly
1.4 reported.
Rheumatic heart disease nothing.
So you can see the question, right, Stallions?
yes we can see
Okay, so are you ready for the first question?
wait
Moderate.
moderate
लेकिन gradient not gradient so here was क्लास 3 डिस्निया के साथ आई परमानेंट एरियल है GFR में उसका कम है और इनऑपरेबल है और लेकिन एक्सटेंडेड लेकिन एंगुलर कैपिटल की एनुलर कैल्शियम है तो निकल जाएगा
मतलब
सही
हो ठीक और क्लास 3 सिम्टम्स भी है
सिम्प्टोमेटिक भी है
हाँ सही और GFR भी एपेक्सिफार और GI ब्लीड भी
GI प्रीवियस हिस्ट्री ऑफ GI ब्लीड अभी एक्टिव नहीं है प्रायर ऑफ GI को
सही AF
लेकिन अभी रेट कंट्रोल 70 ठीक है बस ठीक है
Okay, so I think you've had enough time. Everyone should be ready now. We are going to start with the first question. Can we have the question number 1 on the screen, please? Aga Khan, read the question. Aga Khan Stars, you have to read the question, please. You have to unmute and read the question with all the options. We can't hear Aga Khan. Aga Khan, we can't hear you. So, you have to switch your mic on. You have to unmute.
Can you hear us now?
Yes, we can hear you now. Okay, read it.
Yes. Okay, which statement best characterizes MAC-related degenerative MS in contrast to rheumatic MS in terms of mechanism and therapeutic implications? Options are A. It is a distinct, typically elderly phenotype with complex anatomy. Option B. Commissural fusion is the dominant mechanism. Option C. Leaflet pliability is preserved. Option D. It usually presents with isolated regurgitation without stenotic physiology. Option E. It is predominantly a disease of men with favorable surgical outcomes.
All right, so you've got 60 seconds on your side. Seems like a pacey delivery. Let's see what happens. Okay, and the team which is answering, we want them to be unmuted. We want to hear the discussion. Stallions, unmute yourselves.
Come on, actually. I said, it is predominantly a disease of men. Yes.
Approaching 25 seconds.
So,
15 seconds. 10 seconds. Come on. Which one?
option A.
Okay,
Alpha.
so they have asked me to lock option A just at the last moment. A alpha. So we are going to lock A alpha. And yes, that's a wonderful start. There was a bit of a confusion, but I think it has worked for them. It was a pacey delivery. They've cut it well for a 6. Very well done indeed. Great start. That's what we are here for. Good going. Okay, question number 2 on your screen.
Can you hear us?
Yes, we can.
So second question is of in MAC related degenerative MS, which non-invasive index has the strongest evidence base for risk stratification when planimetry is unreliable. Option A, pressure half-time derived valve area. Option B, three-dimensional continuity equation. Option C, Doppler derived mean transmitral gradient at rest. Option D, Gorlin valve area at catheterization. Option E, mitral annular diameter by M mode.
Your 60 seconds are on your screen.
Non-invasive, most reliable evidence. Non-invasive index is the strongest evidence for this. Risk stratification का पार stronger.
मुझे तो ये तो प्रेशर ग्रेडियंट पर है ना
तो ये कौन से में A और C में मुझे confusion है.
Okay, so just been informed, Professor Amber Ashraf has joined us. Welcome, ma'am. Great to have you, like always.
C.
Thank you.
C for Charlie.
15 seconds
Option
to go.
C.
Come on.
Option C, Charlie.
Are you sure about it, C. Charlie?
Yes.
Okay, they seem to be sure. They want me to lock C. Charlie. An interesting delivery. It was moving a bit. Let's see what they've done. Lock C. Charlie. And you've done it correctly. Wonderful. Again through the offside for a 6. Very well played. Good discussion. And I think you were on the right track. Very well done indeed. That was a beautiful
Good start,
question.
Hamza. Good start.
Great, sir. Great start and wonderful question. I mean, I've enjoyed it. And I'm sure you must have felt the same thing, all of you.
Yes, indeed.
Okay, so moving to the third question. Can you hit the third one for a 6 as well? That will be a hat-trick of 6s. Aghan, start the question, please.
So third question, given the absence of commissural fusion in this patient, which statement about percutaneous mitral commissurotomy is most accurate? A, PMC is feasible if the Wilkins score is less than or equal to 8. PMC should be attempted after CT confirms bulky calcium near the LVOT. C, PMC with undersized balloons can palliate MAC stenosis safely. Option D, PMC is not appropriate. Option E, PMC becomes appropriate once atrial fibrillation is rate controlled.
Start the timer, 60 seconds. Again, it's a good pacey delivery. Let's see how they negotiate. I can't hear the discussion. Stallions, unmute.
Mute now.
PMC is because that's
So we should lock D, na?
PMC.
D delta. Lock option D delta.
Are you sure? Should I lock D delta?
Yes.
So you think it's a third 6?
Yes. Inshallah.
Okay, he says yes, inshallah. Lock D delta and let's see. And it is third 6, 3 in a row. Wonderful start. Great going. That's wonderful play. All right, so we're now going to move to question number 4. Stars, go ahead.
So next question. The heart team is considering a transcatheter mitral valve implantation for valve in MAC. According to the guideline narrative, which single complication has driven much of the early mortality signal and therefore must be the focus of pre-procedural CT assessment? A. Left ventricular outflow tract obstruction. B. Annular rupture. C. Severe paravalvular leak. D. Acute severe MR. And E. Valve thrombosis.
All right, so 60 seconds are on your screen now. And Stallions to unmute. The answering team is supposed to unmute themselves.
We should think that's right,
Good transcatheter procedure. Oh, the transcatheter gives some complication with mortality, but it's
But
yes, E या D.
मुझे ऐसा लग रहा है ना कि acute
Paravalvular leak the severe MR they are sensitive.
25 seconds.
D come.
20 seconds. This one is an off cutter coming in. 15 seconds.
उसके लिए तुम लोग
Procedure.
10 seconds.
करवाया.
Hurry up. 6.
Option D.
D delta. Okay. So just in the nick of time, they've said D delta. Let's see what happens. Is it going into the stumps or out of the boundary? Lock D delta.
Change कर सकते हैं.
Oh no. Your time was up. Unfortunately, your time was up. You said D delta. And that's your first wrong answer. Never mind. You're playing very well. And even the best of us make mistakes. So, but you've got to be careful for the next ones. And we can still have a very good total. Great going. Question number 5 on your screen.
So next question. For an inoperable patient with symptomatic MAC stenosis and favorable landing zone on CT, which transcatheter strategy has preliminary feasibility in experienced centers? A. H2H leaflet repair directed at the A2P2 scallops. B. Inverted balloon expandable transcatheter aortic valve prosthesis implanted in the mitral position. C. Transseptal balloon valvuloplasty of the MAC ring. D. Alcohol septal ablation alone without valve therapy. E. Heterotropic caval valve implantation.
And the timer is on the screen. 60 seconds coming your way.
Symptomatic pressure and favorable landing zone on CT. Which transcatheter strategy has preliminary feasibility? land دريه متى
D और E नहीं है.
D وE खुना
E नहीं है. H2H
ده فقط ده كده أخذت الدورة بس صغير.
30 seconds.
كم يوروك؟
B क्योंकि उसमें ना उन्होंने कुछ बोला हुआ था एनालिस्ट के बाद कि it's not something बहुत यार
15 seconds.
Option B. Bravo.
B beta. Bravo. Are you sure about it this time? I'm going to lock it now.
Yes, lock it.
B beta. Okay. Lock B beta. And yes, that's the right answer. I think this is where the team comes into play. Great discussion. You were on the right track. And they were ruling out the options, and in the end it was between the two, and they got the right one. Great work. Very well done. I'm sure our respected faculty must be enjoying it. Okay, halfway through, and just one mistake. 4 correct answers. You still have 5 more to go. Question number 6 is on the screen.
So next question, in this MAC stenosis patient with negligible commissural fusion and minimal regurgitation, what is the anticipated effect of transcatheter S to H repair on transmitral hemodynamics? A, it will reduce the mean gradient by increasing orifice circularity. B, it has no effect on gradient because it only addresses regurgitation jets. C, it converts the lesion into pure regurgitation with lower left atrial pressures. D, it risks increasing the gradient by reducing the effective valve area and is therefore not an appropriate therapy for predominant stenosis. E, it is recommended as a bridge to percutaneous commissurotomy.
Start the timer, please.
फिर मतलब द मूव ट्रांस एच टू एच
करेंगे तो ये तो हम the gradient area
Hamza, please ensure discussion in English.
Okay,
Not
okay,
in
sir. I was
Arabic.
about to say that I'll request the teams to discuss in English. That's or at least Urdu.
Although me and Ambar Ashraf knows, but still.
Right. So they got it,
Okay,
sir.
all right.
25 seconds to go. Hurry up.
What should we do?
D.
15 seconds.
Lock option D, delta.
D delta. Are you sure?
Yes.
So he's down on one knee and he's trying to heave it over mid wicket. Let's see where it goes. So D delta. Lock it. And it's a 6. Well done. Great teamwork. You guys are really thinking it out, discussing it well, and very well played. Beautiful answer. Lovely. Okay, moving to question number 7.
So moving on, which single imaging step beyond echocardiography is essential before any consideration of valve in MAC therapy in this patient? A, ECG gated cardiac CT to size the mitral annulus/landing zone and appraise LVOT anatomy. B,
Okay, I'll request everyone, hold on, I'll request everyone to stay quiet please and put yourselves on mute because we hear a lot of crosstalk.
So option B, cardiac MRI with late gadolinium enhancement for fibrosis mapping. Option C, stress echocardiography to quantify dynamic transmitral gradient rise. D, transesophageal echocardiography with contrast to exclude PFO. E, calcium scoring, coronary calcium.
Right, the timer starts now. 60 seconds. Stallions to unmute themselves.
P procedure assessment maybe हमें एक question है ना LVOT और ये calcium scoring doesn't make sense. TE or P4 will be TV. Why would you?
The patient is already आगे क्या मैंने अभी
MRI तो उसने तो average
25 seconds.
It makes sense. Option A, alpha. Lock option A.
Are you sure you want me to lock A alpha?
Yes.
Okay, as sure as they are, they want me to lock A alpha, so we are going to lock A alpha. And it's the right answer. Very well played indeed. I think they really are discussing it well and they are ruling out the options. This is the way to do it. Wonderful, wonderful stuff. Great teamwork and we are thoroughly enjoying it. Well done, great going, and I'm sure it's Aga Khan stars, they are also gearing up. So, we still have 3 more questions to go. We already have a good total, but we want a very good total. All right, question number 8.
So next question. The CT demonstrate bulky calcium projecting towards the LVOT. Which statement best reflects the guideline-informed heart team deliberation regarding valve in MAC feasibility? A. Bulky anterior calcium can sometimes decrease LVOT obstruction risk by stabilizing the prosthesis. B. Bulky calcium near the LVOT increases the likelihood of LVOT obstruction after valve in MAC and may render the procedure prohibitive. C. LVOT obstruction risk becomes negligible if the mean diastolic gradient is less than 10 mm of mercury. D. Paravalvular leak is the only major risk with anterior calcium and can be ignored if landing zone is rigid. E. LVOT obstruction risk is mitigated simply by choosing the larger valve size.
And your 60 seconds start now.
In visibility, ठीक है? मतलब हम बीच बात पे bulky calcium near the LVOT increases the likelihood of LVOT obstruction after the valve in MAC and made under the prohibited. तो हम अपनी statement को लगाएंगे ना कि हम
तो उसको बता रहे
नहीं उसको नहीं पता render the procedure prohibited मतलब कि नहीं हो
नहीं हो
सकता bulky anterior calcium can sometimes decrease LVOT obstruction risk for stabilizing
बस ये भी
नहीं है LVOT obstruction mean diastolic gradient is less than 10 उसके बाद
25 seconds. Spinning delivery it is.
may render the I would go for B. I would go for B. Lock option B.
Are you sure you want me to lock
Yes.
B beta, right?
B. Beta, bravo. Yes.
Okay, beta, bravo. And are we going to say bravo at the end of it? We'll see. So lock B beta and let's see. And bravo it is. Well done. Nicely done. Oh, it wasn't that simple. I could see that. But I think the way you discuss, it's great teamwork once again. They are complementing each other, they are discussing it well, and they are utilizing the time beautifully. Well done, very well done indeed. So, 8 questions so far, the score is 42. 2 more to go. Question number 9 on your screen.
So next question. For hemodynamic assessment is MAC stenosis at rest. Which interpretive principle is most appropriate when relating mean gradient to clinical status in an elderly patient with atrial fibrillation and CKD? A. The mean gradient alone should determine therapy irrespective of flow state. B. Pressure half-time is independent of hemodynamics and supersedes gradient. The mean gradient should be interpreted in the context of flow/heart rate, recognizing that low output states may underestimate true severity. D. The Gordon area from cath is flow independent and should replace echo indices routinely. E. Only exercise derived gradients are clinically meaningful in this population.
60 seconds on your screen.
The mean gradient, it's
interpreted in context of low heart rate recognizing that low output states may underestimate severity.
that. C.
Time
और E तो exclude होगा.
E or D भी exclude होगा.
E और D exclude होगा. तो
the mean gradient alone should determine with respect to
C. Please lock C.
mean gradient should be interpreted in the
It makes sense.
context.
25 seconds.
C. Option C. Charlie.
Okay, C. Charlie. So you think you've gone for a big 6 this time as well?
Hopefully.
Hopefully. Not so sure this time. Okay, let's
Sure.
see. Lock C. Charlie. And you have done it again. Oh yes, very well done. Very well done. So they are not wavering and they are just, proving themselves on every question, every delivery, and it's going for 6s. So it's raining 6s at the moment. Well done. Ma'am says superb and super. Yes, ma'am, they have done very well so far.
Thank you.
Very
What
well
an
done.
excellent performance. What an excellent performance.
Great performance, sir. Absolutely. But I tell you, we've got our Khan stars, and I'm sure they are going to match it as well. So it's going to be a tough game. That's what we are hoping for. So, moving to the last question of this innings. Question number 10 on your way.
So last question. In centers pursuing valve in MAC, which programmatic requirement is emphasized by the international guidelines to optimize outcomes and mitigate risk? A. Procedures can be undertaken in medium to low volume centers with caveats. B. Cases should be undertaken after failed balloon valvuloplasty. Option C. A routine transapical approach eliminates LVOT obstruction risk. D. General anesthesia is contraindicated in CKD, thus local anesthesia is mandatory. E. Cases should be concentrated only in experienced centers with careful CT-based planning and hard team selection.
All right, 60 seconds on your
Option
screen.
Option E.
Are you sure about it? I don't even see you. Yes, there you are. He's come down the wicket. He's taken it somewhere mid-air and he's going for a 6. Are you sure about it?
Echo. Last option.
Epsilon. He says he's pleading to me. Echo, epsilon, everything. Okay. He's so sure. Ishaq Saab is not happy. I know one thing for sure. Lock it this time.
It's okay if they are so sure. Go ahead.
Lock it. Oh, yes. Superb. Outstanding. I think this is brilliant work and I've really enjoyed it. I mean, I think we do a lot of matches, but this performance is one that I'm going to remember. That's one thing for sure. And I do see the bright, shining face that is in front of me, Professor Ishaq Saab. Sir, straight away your thoughts.
What an excellent performance. I mean, amazing. Really amazing. And I don't know how they did the second question wrong, you see. One question wrong. I think I'm very glad to know that mitral valve is relatively less discussed condition, but very common condition in our country. So we are so much overworked with the coronaries that we forget the mitral valve management. So I think the question was very good. The scenario was excellent and the questions are very, very relevant. One or two a bit difficult as well, but they did very well. So hats off to the team from Hyderabad Medical Complex. Excellent performance. And I'm so glad to see Ambar Ashraf smiling as well. So let's see what AKUH does. I come from Peshawar and I worked at AKUH. So I've got my hearts on both sides. So I think they'll also give a good performance, inshallah. So once again, well done, HMC Warriors. Well done.
Thank you very much, sir, for your wonderful comments. And I think I see Professor Ambar Ashraf. Madam, you're there. We have to take your thoughts now.
Thank you very much. We really enjoyed this match. And we hope the rest of the teams do come prepared in the same way, because that highlights the PGs are working day in and out. And the topic is very interesting. And important thing is every day, especially in our country where low socioeconomic conditions are there, and these diseases are the diseases of South Asian country, and one must as a cardiologist know the diagnostic parameters, where to go and how. Salute to Hyderabad Medical Complex team, and we are waiting for AKUH. Definitely the people are doing much better than us in Karachi. But I love the statement of Professor Ishaq, अफसर का दिल दोनों तरफ है, देखते हैं कौन जीतता है. और हमजा आपकी मॉडरेशन तो वैसे ही माशाल्लाह सुपर है.
Thank you very much.
Thank
you very much, ma'am. I think you are the real stars, and I think these teams, they make it so wonderful. And I was just doing a case of a very calcified bad LAD, so I had to rotablate it, and I thought maybe that's going to be the highlight, but I think this mitral valve in this particular performance seems to be taking the cake for me. Wonderful, and I'm so excited. And I have Professor Feroz Memon Saab. Sir, your thoughts, please. Sir, you'll have to unmute, sir. Is Feroz Saab there? Okay. I think he's unable to hear me, so we have Professor Asghar Saab. Sir, he's the mentor. Yes.
Thank you very much. Thank you very much.
Your team performance was brilliant.
Of course, and it's we should think on the other way. The questions were difficult, very difficult, and they were on structural heart. So you basically the Cardiac Society is paving the way for basically introducing the structural heart disease to Pakistan. I think and our team definitely performed very well. I am proud of him. Thank you very much.
Professor Memon is there now.
Sir, Professor Memon, Feroz Memon Saab.
वालेकुम सर हमारे एक्चुअली प्रॉब्लम ये कि बारिश के बाद वाईफाई सारा डिस्टर्ब है तो आई एम नॉट एबल टू हियर अ लॉट से अ लॉट लेकिन एक बात मैं जरूर कहूंगा द प्रोग्राम हैज बीन रियली वंडरफुल वेरी नॉलेजेबल और जो हमारे मॉडरेटर साहब हैं तो आई ऑलवेज प्रेज फॉर हिम कि ही हैड मेड दिस प्रोग्राम ऑल स्टैंडर्ड वन थिंग एंड इसको बहुत इंटरेस्टिंग किया आई विश बेस्ट ऑफ लक टू एचएमसी पीपल एंड आखान स्टूडेंट्स इंशाल्लाह वी विल सी देम इन लाहौर एंड थैंक यू वेरी मच सर फॉर आस्किंग मी टू पार्ट ऑफ दिस प्रोग्राम.
Thank you very much, sir. Your comments and your views are extremely important always, and you come up with some great highlights. And we do have the coach of Hayathabad. I think he's there with us. We have do we have him there? Yasir, Dr. Yasir Hayat. Is he there?
Ji, yes, I'm here.
Dr. Saab, your team has done very well. Your thoughts?
Excellent performance. It's beyond my expectation. I was not thinking that much, but they have proven themselves. They are excellent PGs and they are very hardworking. Especially they touch structural heart disease and they perform so much well. बहुत ज़बरदस्त किया उन्होंने और मेरी तवक्कुआत से बहुत ज़्यादा किया और इंशाल्लाह हम लोग आगे भी दिखाएंगे इंशाल्लाह कि हम अच्छा खेल सकते हैं और उम्मीद है इंशाल्लाह आगा खान की टीम भी ज़बरदस्त खेलेगी और आई एम सो मच प्राउड ऑफ देम. थैंक यू सो मच.
Thank you very much, Dr. Yasir. Some great comments, and I know it's just halfway. They've done brilliantly well, but it's just the halfway stage. And Aga Khan stars are there, and we all know they've proven that they're always there and performing like stars. So, can I have the stars on screen, please? Can I have Aga Khan stars on the screen? Okay, stars, are you ready?
Yes, we are ready.
And we are hoping for a wonderful reply from your side. Best of luck to you, and it's going to be brilliant. So with this, I'm going to start with the second innings. Can we have the vignette, the scenario on the screen, please? And I'll request Hayathabad HMC Stallions to read it.
32-year-old woman from a low resource setting presents with 6 months of progressive exertional dyspnea, NYHA class 3 and orthopnea. She had rheumatic fever in childhood. On examination, her blood pressure is 110 by 68 mm of mercury and her heart rate is 96 beats per minute in sinus rhythm with an elevated jugular venous pressure. Cardiac auscultation reveals a loud S1, an opening snap and a low pitched mid diastolic rumble at the apex with pre-systolic accentuation. Transthoracic echo of good quality shows a mitral valve area of 1 centimeter square by 2-dimensional planimetry, a mean transmitral gradient of 13 mm mercury at a heart rate of 96 beats per minute, mild mitral regurg, an estimated systolic pulmonary artery pressure of 48 mm mercury, and a marked left atrial enlargement. Right ventricular size and functions are normal. A pressure half-time derived valve area reads 1.5 centimeter square. Transesophageal echo is scheduled before the intervention to exclude thrombus and assess the commissural subalveolar anatomy. The heart team at an experience center is considering percutaneous mitral commissurotomy and the patient wishes to conceive within the next 6 to 12 months.
Okay, so stars, you have a couple of seconds. You can gather yourselves, and once you're ready, we'll start. And I'll request the answering team to unmute themselves when they're about to answer. So always remember this. Stars, can you unmute, please? Okay.
Yes, we are unmute.
And you ready now?
Ready? Okay. Yes, proceed to the questions, please.
Okay, proceed to the questions, please. First question on the screen, Stallions, Read the question.
When assessing mitral valve area in this patient, which statement best explains why two-dimensional planimetry should remain the reference against which other indices are reconciled? Option A, two-dimensional planimetry directly measures anatomical orifice area at leaflet tips and is less flow dependent than pressure half time or gradients. Option B, two-dimensional planimetry is independent of image plan and never underestimates area in the rheumatic disease. Option C, two-dimensional planimetry is always concordant with the Gorlin formula in catheterization laboratories. Option D, two-dimensional planimetry becomes unreliable specifically after commissurotomy and should be avoided pre-procedurally. Option E, two-dimensional planimetry is inferior to continuity equation area where there is mild MR.
And the timer is 60 seconds and it's on the screen and you have to unmute stars.
Two-dimensional plani जो है वो directly measure करती है anatomical orifices लीफ पे टिप भी आ जाती है और less flow dependent है, this is true. बाकी दोनों चीजें flow dependent होती हैं, ठीक है. अब inferior कभी भी नहीं होती, E खाली है, ठीक है. A सबसे ज़्यादा सही लग रहा है. Becomes unreliable, ये मुझे नहीं पता. I think I'm sure.
C तो नहीं है, C और D is not.
नहीं हाँ ठीक है. I don't think so. नहीं.
25 seconds.
I think A is the answer. A.
Go with A.
15 seconds.
So we'll go with alpha A.
Are you sure you want me to lock A alpha?
Yes, A.
Okay, lock A alpha. Oh yes! You know, I really enjoyed this first answer because that sets the tone right, and the way you guys have done it again, I think we're gonna have a very tough competition. Great understanding of things, again great teamwork, and I see a touch of brilliance there. Nicely done. Okay, really excited. Question number 2 is on your way.
Question number 2.
We can't see the screen, please hold on.
Okay, hold on. Technical team, is there a problem? There is some distortion, I think we can also hear that. So we are going to hold on.
HDMI निकाल के दोबारा लगा. अभी बस हो जाएगा फिर.
Okay, so is it okay now?
Wait, आ जाएगा.
No, we need more time.
Okay, you'll get more time, don't worry. We're not going to start until you have everything ready and you can see everything. Technical team is on it.
We can see the screen.
Okay, so everything is back on track. You can see the screen. Okay, so you're ready?
Yes, we are ready.
Okay, question number 2. Read it, please. Stallions.
If the pressure half-time derived valve area disagrees with planimetry in this sinus rhythm patient, which pathophysiological factor must plausibly account for an overestimation of valve area by pressure half-time at baseline? Option A, atrial septal defect with left to right shunt increases E-wave velocity time integral. Option B, pressure recovery in the left atrium leads to underestimation of pressure half-time area. Option C, tachycardia and altered left atrial and left ventricular compliance, shortened deceleration time, inflating pressure half-time based area. Option D, post-commissurotomy changes cause pressure half-time to systematically underestimates area at baseline. Option E, right ventricular diastolic dysfunction prolongs pressure half-time and underestimates valve area.
And you have 60 seconds now.
एट्रियल सेप्टल डिफेक्ट जब होगा ना और लेफ्ट टू राइट शंट होगा तो वॉल्यूम ज़्यादा जाएगा. समझ रहे हैं? तो ये क्या कह रहा है कि लेफ्ट टू राइट नहीं, लेफ्ट टू राइट शंट. हाँ तो कम हो रहा है. हाँ तो ये गलत है ना, डिक्रीज हो जाएगा.
सी मुझे सबसे विजिबल लग रहा है. इसको टैकीकार्डिया एंड ऑल्टर्ड लेफ्ट एट्रियल लेफ्ट वेंट्रिकल डिसेलेरेशन टाइम, inflating pressure time based area.
25 seconds.
ए हमने निकाल दिया, फिर भी बाकी ऑप्शन लिखने हैं. बी के बराबर प्रेशर रिकवरी अंडर एस्टिमेशन ऑफ प्रेशर हाफ टाइम एरिया.
C सही लग रहा है.
15 seconds. It's a moving delivery, pacey one. 10
We'll
seconds.
go with C, Charlie.
Are you sure about it? You want me to lock Charlie?
Yes.
He says yes, lock Charlie. He seems to be quite sure. He's going for a flick over mid-wicket. Let's see, lock C Charlie then. And the flick is going for a huge 6. Well played. Oh yes, I saw the Marquardt in you. You used to flick so well. Well done, very well done. Brilliant. I think that's great going so far. So I see a brilliant match in the making. Two fantastic teams are up against each other. Keep it up. Okay, question number 3 on your screen now.
Before finalizing intervention, what is the single most impactful optimization to improve the interpretability of the resting mean transmitral gradient in this patient? Option A, administer IV fluids to raise the preload and increase gradient for severity confirmation. Option B, begin nitrates to lower left ventricular and diastolic pressure and raise the transmitral gradient. Option C, perform dobutamine stress echo to unmask latent severity. Option D, add an angiotensin converting enzyme inhibitor to reduce the afterload and gradient. Option E, institute heart rate control, for example, a beta blocker to reduce the rate related gradient augmentation.
And you have 60 seconds.
We're going for E for elephant.
Oh my God, she's come down the wicket. In fact, they've come down the wicket and they are going for a huge 6. And this is going over long on. So, are you sure?
Yes, we're sure.
Which one should I lock?
E for elephant.
Okay, E for elephant. My heart is in my mouth. Lock E for elephant and let's see. And yes, it's a 6. Very well done. They were so sure. Brilliant. And that's another hat trick by you in the first 3 questions. So both the teams have correctly answered. The first 3 questions. Superb, madam. I think absolutely superb performance. Great going, great match. And we're really enjoying it. It's a privilege today for all of us. Okay. Question number 4 is on the screen now.
If symptoms seem disproportionate to resting indices, which testing approach best clarifies hemodynamic limitation in rheumatic mitral stenosis? Option A, supine bicycle or treadmill exercise echocardiographic to assess the change in mean gradient and pulmonary pressures. B, dobutamine stress echocardiography to increase stroke volume through the stenotic wall. Option C, right heart catheterization in all cases is first line. Option D, cardiac magnetic resonance for direct valve area planimetry. And option E, computed tomography calcium scoring to quantify the commercial calcification burden.
60 seconds on the screen now.
लेकिन एक मिनट डीएससी है या सुपाइन बाइसिकल है ये मुझे नहीं पता मैंने कराई है यस आई थिंक ए सुपाइन बाइसिकल कोई ज्यादा हां ए सेंस बना
25 seconds around the wicket, so maybe swinging away.
Okay, we'll go with A, alpha.
Are you sure about it?
Yes.
He says yes. The captain seems to be sure. An outswinger from around the wicket. Let's see whether it's a snick or it's a 6 over covers. Lock A alpha. And it's a 6 over covers. Beautiful. Once again, brilliant answer. So you got the 4th one correct as well. And Stallions, they had missed the 4th one. That's the only mistake they made. Remember that. So you still have to go a long way. You're 24 in 6 and you have to beat 54. Okay, that means you have to correctly answer all the questions to win it straight away. Otherwise, one blemish and we'll have a tie and we'll go into the next stage. Okay, that's superb stuff going on at the moment. And it's question number 5 on the screen.
On pre-procedural transesophageal echo, which specific anatomic constellation most strongly predicts a poor splitting result and high risk of significant post-commissurotomy mitral valve regurgitation? Option A, isolated commissure fusion without calcium and thin subvalvular apparatus. Option B, bicommissure calcification with restricted leaflet mobility and marked subvalvular thickening. Option C, a large left atrial volume index with no commissure calcium. Option B, minimal subvalvular involvement with pliable leaflets. And option E, posterior leaflet prolapse with central regurgitant jet.
Start the timer, 60 seconds on your screen now. So, stars, unmute please. We can't see them. So do we have Aga Khan there? We can't see them or hear them. Unmute please, unmute.
तो मेरे ख्याल में तो A वही जा रहा B. मेरे ख्याल B ज़्यादा लग रहा है.
20 seconds. 15 seconds.
Okay, we'll go with B, ball.
B beta, ball. Oh yeah, that's a good analogy, ball, since you know. So, B beta, should I lock it?
Yes.
Okay, lock B beta and let's see what happens. Oh my god, it's another one. Another correct answer. It is absolutely raining sixes everywhere now. Brilliant, brilliant performance.
Interrupted again.
Sorry? I didn't get it. So, is there a technical problem?
We can see the scene.
Okay, you can see it now. All right. Is everything good on your side, Aga Khan?
Yes.
Great performance. So you've correctly answered the first 5 questions. Very well done. It's very much anyone's game. Still 5 more to go. Stallions, keep your chins up. Anything can happen. It's a tough fight and you've also done brilliantly well. All right, question number 6 is on the screen now.
If dense left atrial appendage thrombus is found on transesophageal echo, which anticoagulation strategy aligns with ESC guidelines prior to any pre-cutaneous commissurotomy? Option A, switch to non-vitamin K oral anticoagulation for 4 weeks and re-image once. B, start dual antiplatelet therapy for 6 weeks and proceed regardless of thrombus status. C, use low molecular weight heparin indefinitely and forego repeat imaging. D, begin vitamin K antagonist with a target INR of 2 to 3 and repeat imaging until thrombus resolution. Perform commissurotomy under intensified heparinization without delay.
And the timer starts now. You can.
पर हम थ्रोम्बस ब्रीड कर रहे हैं.
Okay. So it's a flighted delivery falling into the hitting zone. Let's see. But it's spinning, so you never know.
We'll go for D, doctor.
D, doctor. Okay, are you sure, doctor? He says, I'm sure. So it's a flighted delivery. It's a leg spinner. Let's see if he's gotten it right or it turns out to be a googly. Lock D, delta. And yes, it's brilliant. Another one. My goodness, even I'm getting excited here. So beautiful 6. Well done. And another one correctly answered. 6 in a row, 6 on the trot. Beautiful answering. Great teamwork and very well done. Superb. You see, I'm actually running out of superlatives at the moment, the way things are for both the teams. So, 4 more to go. And I'll request Aga Khan to unmute while the question is going, to mute yourselves when the question is going on and unmute once they're done with. You start discussing once they're done with their question and reading of the question. Okay, so question number 7 is on the screen, please.
The patient develops new onset AFib on the morning of the planned percutaneous commissurotomy. Which sequence is most consistent with the guideline directed care? Option A, perform immediate electrical cardioversion and defer commissurotomy for 3 to 4 weeks thereafter. Option B, proceed with commissurotomy first and consider cardioversion soon after a successful intervention. Option C, load a non-vitamin K oral anticoagulant and cardiovert prior to any valve intervention. Option D, cancel the procedure and anticoagulate vitamin K antagonist for 3 months before its reassessment. Or option E, undertake pulmonary vein isolation before any commissurotomy.
Aga Khan, stars, you have 60 seconds.
न्यू आंसर है तो वी हैव टू
यस और दूसरा अगर वार्फिन लोड होगी तो एक्सेस नहीं होगा ठीक है तो वो तो गया तो नॉन विटामिन के छोड़ दें कैंसिल द प्रोसीजर छोड़ दें पल्मोनरी वेन आइसोलेशन
डिफर विद फर्स्ट में भी कर रहे हैं
Can you tell the technical team?
Yes, sir. I think they are back. 25 seconds to go. Everyone is in fact on the edge of their seats. You have 15 more seconds.
We'll go with A, alpha.
Are you sure? You want me to lock A alpha?
Yes, A.
He says yes, A. Whenever he says yes, then that means he's sure. And the team is sure as well. He's backed up by his team. I'm going to go with A alpha. Lock it. Oh my goodness. Oh no. Oh my God. That's the first blemish. And we've missed the first one. And that one came in, hit the middle stump. Okay. So, never mind. Now it's getting interesting. You still have 3 more to go. And you've got no margin for any errors. And the way you are going, we may get into the next phase. And that's a decider with 2 more questions on both the sides. Okay, get up for question number 8.
If post-commissurotomy, the patient develops acute severe mitral regurgitation due to leaflet tear, which immediate strategy is the most appropriate? Option A, conservative management with diuretics and watchful waiting. Option B, percutaneous edge-to-edge repair to clip the torn segment immediately. Option C, repeat balloon inflation to ensure full commissural splitting. Option D, urgent surgical mitral valve repair or replacement given severe post-procedure regurgitation. And option E, switch to afterload reduction to reduce the regurgitant fraction and discharge.
60 seconds, start now. Okay, you'll have to unmute, Aga Khan. We can't hear you. Stars, we can't hear you. Aga Khan, unmute. Totally absorbed in the game. 25 seconds to go. 20 seconds.
Okay, we'll go with D, doctor.
Okay, he says D, doctor, and whenever he says D, doctor, I have a feeling, he may be right. So, I'm going to lock D, delta, and with fingers crossed, lock D, delta. And yes, you were right. Very well played. You were calm and composed, no fidgeting. They knew what they were heading for. Beautifully played. Very well done. Wonderful answering, wonderful teamwork. And it's great to be here today. So we still have 2 more questions to go. They have to correctly answer both the questions. If they miss any of the questions, then we know the outcome. Stallions are going to win it. But then, you never know what's in store. Question number 9 is on the screen.
In a symptomatic patient with borderline anatomy, for example, an echocardiographic score of 9 to 10 but favorable commissural morphology, which statement best reflects the EAC approach in experienced centers? Option A, surgical wall replacement is mandatory once the total score exceeds 8. Option B, commissurotomy is contraindicated when the total score exceeds 8 regardless of the clinical status. Option C, edge-to-edge repair should precede commissurotomy to reduce regurgitation risk. Option D, right heart catheterization should replace echocardiography for decision making. And option E, percutaneous commissurotomy may be considered as initial treatment in experienced centers after heart team discussion.
And 60 seconds start now. That's a bouncer. Let's see how they negotiate.
After heart. 8 to 11 जो होता है वो ग्रे एरिया होता है उसमें APTMC हो सकता है अगर everyone is agreeing.
We'll go with E, elephant.
Okay, this could be the elephant in the room as well. Anyhow, they want to go with E epsilon, elephant. So are you sure about it? Should I lock it?
Yes.
He says yes, lock it. So team, lock it then. And brilliant answer. I think the way you've done it, brilliant. So you were ruling out, excluding the options, and then pinpoint, bang on target. Oh, beautiful work. So definitely I think it's a masterpiece in the making. And we still have the last question, and so much is banking on it. This is called going to the wire. Okay. Best of luck to both the teams. We're going to the last question, probably, of this game. Let's see. It may not be the last. Question number 10 on your screen.
If pulmonary hypertension on echo were the sole criteria supporting surgical consideration in a patient otherwise borderline for intervention, which verification step does EAC recommend before committing to surgery? Option A, proceed to surgery because echocardiographic pulmonary pressure surface is in inexperienced labs. Option B, perform dobutamine stress echo to exaggerate pressures. Option C, confirm the pulmonary pressure with invasive right heart catheterization before surgery if pulmonary hypertension is the only driver. Option D, undertake cardiopulmonary exercise testing instead of invasive assessment. And option E, estimate the pulmonary pressures by cardiac magnetic resonance phase contrast imaging.
60 seconds are on your screen.
So we will go with C, Charlie.
What about it? You want me to lock it?
Yes, we are sure.
This is your last question. You can't get it wrong. You know that.
Yes, C. Yes, please lock C.
We are all on the edges of our seats, respective seats. We don't know what we're going to have. I really have no idea what we are heading for. Maybe, maybe not. Okay, so it's getting exciting now. I'm going to lock C, Charlie. And it's a 6. Very well done. And you've smashed it for a huge 6. Brilliant, brilliant performance by both the teams. And I think, you know, our faculty is there, our panel of experts. So, sir, just quick thoughts from everyone.
Thank you, Hamza. What an excellent performance by both the teams. And amazing match. I enjoyed every bit of it. Both of them are highly learned. My congratulations to both of them. And it's a tie now. So we have to throw some questions to make a decision then. I don't know how it's going to work out. But anyhow, दोनों को जुर्माना होना चाहिए. एक गलती क्यों की है इन्होंने? एक गलती भी नहीं करनी चाहिए. They were so good. Why they did one? ये क्या मजे के लिए गलती की है इन्होंने? I think they knew the subject. Subject was excellent. Questions were good. Scenario was excellent. And both the teams have performed superb. It was one of the best matches I've seen so far. So my congratulations to both of them, both the teams. और जैसे अंबर ने कहा था, मेरा हार्ट तो दोनों तरफ है. I've been in AKUH for 35 years and I belong to Peshawar. So Peshawaris must have consumed some Chersi tikkas to give such a good performance. I don't know why they did one mistake. But anyhow, both the teams have done wonderful. Wonderful.
Great performance indeed. I think it was Charsi Tikka from Peshawar and I think Karachi Biryani, something like that for Agha Khan.
Yeah.
Superb, superb. And I've just been informed that I think the next stage is going to be a sudden death.
Yes, we've got some 5 questions, I think, in the bank, which we can throw and come to some decision. But both the teams ought to be congratulated. They ought to be awarded.
Absolutely
right. ठीक कह रहे हैं
सर मैडम
सर आप ठीक कह रहे हैं बिल्कुल हम आगे भी कर सकते हैं लेकिन जितना अच्छा इन दोनों ने प्ले किया वी आर प्राउड of both the teams and their mentors and supervisors. सर देख लें अगर इस तरीके से है तब भी अच्छा है और अगर नहीं है ऐसे तो हम बाकी टीम्स के जैसे टोटल स्कोर्स हैं उसमें देखें तो ये 54 है तो फर्स्ट सेकंड थर्ड करके जो लास्ट उसमें है दैट विल बी अ वन अनदर ऑप्शन जैसे भी सब कहें
मेरा ख्याल है सडन डेथ कर लेते हैं क्योंकि दोनों बड़ी टॉप की टीमें हैं इनसे एक को ऊपर आना चाहिए
Agree, sir. Go ahead then.
I think, sir, very extremely valuable comments, but it's the knockout stage for everyone. So I think we'll have to play for a knockout, and we need one winner. So, but I think they both deserve to be the winners. It's just the format of the game, and I'm sure that both of them, they are pretty confident. And I think we'll have one winner, but for us, everyone is a winner today. So with this, I think we're going to move ahead and we'll have the first question. So I think we will have the first question from HMC Stallions. So they'll be reading out the question. Okay, no, they'll be answering. We'll follow the format. So I think Agha Khan, you'll have to read the question, the first one, and HMC Stallions will be answering it, and then we'll have the next question. So we'll have 5 rounds each. And it's a knockout. So let's start with the first knockout question.
Okay. So next question.
And these questions I want to make it clear. Hold on please. Hold on.
Class 3.
Hold on please. Hold on. I want to make it clear the questions are actually from the same cases. All right. So this is the 11th question and the first knockout question. Let's see. So please now, Agha Khan stars, start reading. And if you want to see the scenario, you can ask for it. We'll show it to you.
If symptomatic status remains New York, so if the status remains New York Heart Association class 3 with mean gradient of 9 and valve area around 1.4 centimeter square, which management goal is most consistent with guideline intent when valve in directed medical therapy and multidisciplinary care? B. Escalation to surgical valve replacement irrespective of prohibitive risk. C. Mandatory dobutamine stress echo to upstage severity. D. Immediate transcatheter S2H repair to reduce LA pressure. And E. Emergency mitral annular calcium debridement.
Stallions, your 60 seconds start now. Unmute.
Stevia, okay.
Why would you?
Immediate transcatheter.
E तो हम करते ही उसके लिए ना A से A radiation symptoms directed medical therapy
B नहीं हो सकता C नहीं हो सकता
A option A alpha.
So you still have half the time left. Are you sure?
Yes.
Which one should I lock?
Alpha. Option A.
He says alpha. Lock A alpha. All right. It's a knockout stage and I'm going to lock A alpha. And he's so very right. He smashed it for a huge 6. Well done. Wonderful answer. And that's what we've seen all day long. 6s all around. Very well done. Well played. Now the pressure is on the stars. Agha Khan stars. Okay. So can we have the next question from the other case for Agha Khan? Start please. Stallions.
For an is
Stallions will read the question. Stallions read the question. Agha Khan, mute yourselves.
For an asymptomatic patient with clinically significant rheumatic mitral stenosis, which single scenario most strongly prompts consideration of intervention despite the absence of resting symptoms? Option A, a plan to conceive within the near term. Option B, left atrial diameter of 35 mm. Option C, a body mass index of 32. Option D, an estimated systolic pulmonary artery pressure of 45 mm mercury at rest. And option E, a Wilkins score of 7 with pliable leaflets.
60 seconds on your screen, Aga Khan.
एक patient asymptomatic है, MS है, which scenario most strongly prompts consideration of intervention? अगर asymptomatic patient है तो उसमें surgery का क्यों मतलब procedure क्यों कर रहे हैं? अभी इसने conceive भी करना था तो 3 to 6 months मेरे ख्याल में तो ये है unstable हो जाएगी वरना LA BMI इनकी वजह से ये तो 2000
इसको फिजियोलॉजी का मसला है, यही होगा। आपको लग रहा है? सोचने में
मेरे ख्याल में तो यही लग रहा है।
एस्टिमेट नहीं है तो अभी 45 लेवल हम नहीं कर
और जो सिम्टम्स नहीं है ना, भले 60 का हो जाए लेकिन नहीं।
So we'll go with A alpha.
Are you sure about it? You want to go with A alpha?
Yes, we're sure.
So they are very sure. They want me to go with A alpha. Lock A alpha. And it's the right answer. Brilliant. I mean, that's what we were expecting. I don't expect you to lose questions today because you are doing so well, both of you. Wonderful stars, wonderful stallions, brilliant. So, the first round, I think both teams are again, they're par with each other and one question apiece. Moving to question number 2 for the knockout stage. Read the question, please, Aga Khan.
Okay, next question is of which peri-procedural antithrombotic concern is most specific to valve in MAC compared with routine mitral interventions and influences the heart team's risk-benefit calculus in this CKD patient with prior GI bleed? A. Universal need for dual antiplatelet therapy for at least 1 year after valve in MAC. B. Mandatory full dose NOAC in all valve in MAC patients irrespective of etiology. A nuanced balance between thrombotic risk of bulky calcium prosthesis and high bleeding risk without single universal regimen. D. Complete avoidance of any antithrombotic therapy post-procedure. E. Switching to PAR enteral direct thrombin inhibitors lifelong.
And the timer starts now, 60 seconds.
Mandatory full dose. We have to see the risk assessment or benefit.
Every time जब भी हमने Option C, Charlie.
C, Charlie. You're sure about it?
Yes.
He says yes, and whenever he says yes like this, he's mostly sure, I know. Okay, lock C, Charlie. And he's right, of course. Well done, very well played, superb. Great going indeed. Okay, so, next scenario. Aga Khan, are you ready? Stallions, read it.
If surgery becomes necessary in this woman, which factor most strongly argues against implanting a mechanical wall? Option A, her age 32 years, which favors mechanical durability. Option B, the rheumatic etiology of her wall disease necessitates mechanical prosthesis. Option C, sinus rhythm at baseline favors a mechanical wall because anticoagulation is already indicated. D, her unreliable access to high quality anticoagulation. Her near-term pregnancy plans favor a prior prosthesis in shared decision making. And option E, moderate enlargement of the left atrium is contraindication to bioprosthesis.
60 seconds start now on your screen.
Age is not.
That's a moving delivery. We can't see Aga Khan on the screen. Okay, so what a match.
Okay. So we'll go with D, doctor.
Oh my goodness, it's a doctor again. D, doctor. You want me to lock it? Yeah. Should I lock D, doctor?
Yes.
He says lock D, doctor, lock it. And yes, of course. It's a right answer once again. Very well done. Well played. Okay. Second round. We are still equal. Oh my goodness. What's going to happen? Question number 13.
Okay. Which echocardiographic feature would most strongly argue against attempting valve in MAC because secure anchoring is unlikely? A. Circumferential, bulky annular calcification forming a rigid ring. Sphere left atrial enlargement. C. Mild functional tricuspid regurgitation. D. Mitral inflow E wave deceleration time of less than 140. E. Focal discontinuous calcification with large calcium free segments in the landing zone.
And your 60 seconds start now. This one is reversing. I can see.
D is also.
It's between A, B, and E. So, focal
discontinuous calcification
with large calcium-free segments in the landing zone. Echocardiography against attempting valve in because where anchoring is unlikely.
25 seconds.
And there is this because the secure anchoring is unlikely. Focal discontinuous calcification with large calcium. कुछ प्राची calcification होगी ना?
15 seconds.
Option E, echo.
Are you sure about option E? You want me to lock it?
Yes, lock it.
Okay, he says lock option E, epsilon. Lock option E, epsilon then. Oh yes! That's the right answer. This was a difficult one, reversing in, and you've smashed it for a 6. Great stroke. Wonderful stuff. Can we have the next question? Read the question, please.
In a patient with prior surgical commissurectomy who now has symptomatic restenosis due to commissure refusion and febrile anatomy, which strategy best aligns with ESC guidelines? Option A, percutaneous commissurectomy is
We
categorically...
can't see the question.
Okay, hold on. Can you see it now? Technical team,
Yes,
look
we
into
can
it.
see the screen now.
But you can't see the question.
Yes, now we can see.
Okay, please continue then.
Option A, percutaneous commissurectomy is categorically contraindicated after prior commissurectomy. Option B, repeat percutaneous commissurectomy can be proposed in selected refusion anatomy, otherwise wall replacement is often required. Option C, transcatheter edge-to-edge repair should be performed first to reduce the regurgitation risk. Option D, watchful waiting is preferred because restenosis is typically slow. And option E, immediate surgical wall replacement is mandated in all such cases.
60 seconds are all yours. Let's see. Unmute Aga Khan. We want to hear the discussion.
D और E खत्म हो गए क्योंकि सिम्टोमेटिक को तो छोड़ेंगे नहीं।
हाँ, तो मेरे ख्याल में B.
B is a better option because मैंने repeat करो selected
हाँ, उसको देख के.
otherwise
रिप्लेसमेंट कर दो।
हाँ. Okay, we'll go with B, ball.
B. You want me to lock option B, beta?
Yes, B.
Are you sure about it या जान छुड़ा रहे हैं?
No, no.
Oh, you're playing so well. So you want me to lock B, beta? Okay?
Yes.
I'm locking. Oh, yes. He says yes. Lock B, beta. And when he says yes, just like Stallions, he's also right. Oh, great going. Wonderful. Superb. Superb. So we just have...
ये जंग खत्म नहीं होनी.
Outstanding, sir. I think.
ये ऑपरेशन तंदूर चल रहा है.
सर ये सिंदूर नहीं, ये तो तंदूर चल रहा है.
मजा आ रहा है. Outstanding.
Superb, madam. Absolutely right. And everyone is so excited today, I think. Two teams so well prepared and they're doing it brilliantly. So very well done already. You know, you deserve congratulations. So just 2 more to go. Can we have it on the screen, please? Okay. Read the question, please.
Okay, next question is, assuming the heart team proceeds with the valve in MAC planning, which imaging plane timing is most critical on CT when interrogating the risk of LVOT compromise by an implanted balloon expandable valve? A, end diastolic short axis at the papillary muscle level. B. Mid-systolic long axis reconstructions aligning the LVOT and anterior mitral leaf flat. C. End systolic 4-chamber plane only. D. End diastolic axial stack through the aortic annulus. E. Any non-gated CT slice set is sufficient.
And 60 seconds start now. Is this the toe breaker? Let's see.
किसमें हमें LVOT की compromise हमें नजर आएगा? Compromise है ना?
C, D, E for the sure है,
हाँ,
sure
E भी नहीं है, C भी नहीं है.
और A और B के दरमियान.
And diastolic short to the pectoral muscle level. नहीं, mid systolic long axis LVOT आपने देखा है. हाँ, aligning the LVOT and anterior mitral ligament.
So B, BT.
B. B.
Option B, Bravo.
B bravo. Beta. You want me to lock B beta?
Yes.
Are you sure?
Yes.
He says yes with a smile. I'm going to lock it, please. And yes, he's right. Oh my God. Well done. Superb, superb. Very well done. Can we have the next question on the screen, please? Go ahead. Read it. Read the question.
This question is not ours, I think.
हाँ, ये तो वही है. हाँ, लेकिन वो change question नहीं आया ना?
Change the scenario.
Change the scenario. You'll have to change the scenario, please.
Question. Okay. Which follow-up strategy after a technically successful percutaneous chemotherapy most appropriately reflects guideline intent for surveillance? Option A, transthoracic echo only every 5 years. Option B, clinically review after 3 years in all cases. Option C, yearly clinical and echocardiographic review with shorter intervals if features of restenosis appear. Option D, reassessment only if symptoms recur. Option E, monthly B-type natriuretic peptide checks to detect restenosis early.
Timer starts now, 60 seconds. Oh goodness, let's see. Unmute Aga Khan.
Echo every 5 years.
नहीं करोगे 5 साल. C आंसर है. क्लिनिकल भी देखोगे, एको को भी देखोगे और शॉर्टर इंटरवल्स भी करोगे.
So go with C, Charlie.
You're coming down the wicket and you're trying to smash it for a 6. You have time. You want me to lock
Yes.
C? Charlie. Oh, again he says yes. So you want me
Yes,
to lock
Charlie.
C, Charlie? Okay, then lock C, Charlie. And yes, he's right this time as well. Superb stuff. Superb. With this, we are now moving to the last question, set of questions. I mean, this is the last one that we have. All right, read the question, please.
So in MAC stenosis with coexisting calcific aortic stenosis, which sequencing principle is most consistent with guideline reasoning when both lesions are severe and surgery is prohibitive? A. Address the mitral lesion first to reduce afterload for transcatheter aortic valve implantation. Undertake simultaneous TAVI and valve in MAC to shorten hospital stay. Treat neither valve if the mean mitral gradient is less than 10. Address the aortic valve first with TAVI to stabilize hemodynamics before contemplating MAC-directed mitral therapy. And E. Perform tier 2 first to mitigate pulmonary pressures.
Timer starts now. Stallions to unmute.
No, first हम mitral को address कर लिया. Among A and D one is correct. Like which one should we address first? Mitral को or aortic?
Aortic.
तो
with TAVI to stabilize the
aortic को हम address करेंगे. Aortic को करेंगे अगर.
Aortic first with TAVI to
क्योंकि फिर
stabilize.
हम उससे involve in वो करेंगे ना, तो फिर पहले हमने aortic को ठीक करना होगा.
Address mitral.
25 seconds. Come on, Stallions. I know it's reversing.
Option D, delta.
D delta.
Yes.
Absolutely sure?
Yes.
He says he's absolutely sure on this one. Okay. As sure as he is, the last question for them, and I'm going to lock D delta. Lock it. And yes, that's one thing for sure. You're not going home today. Superb. Superb. Absolutely brilliant.
MashaAllah.
Mashallah ji, mashallah. I think superb stuff. Unbelievable. Okay, so the last question. Read the question for Aga Khan now.
While awaiting intervention, which medical regime best addresses symptoms and hemodynamics without contravening ESC anticoagulation guidelines for rheumatic mitral stenosis? Option A, high dose nitrates in a non-vitamin K oral anticoagulation for reducing the filling pressures. Option B, ivermectin and non-vitamin K oral anticoagulant is default therapy. Option C, dual antiplatelet therapy reduce the embolic risk from left atrial enlargement. Option D, dihydropyridine calcium channel blockade to lower the afterload and gradient. And option E, a beta blocker for heart rate control with diuretics, avoiding non-vitamin K oral anticoagulations.
And your timer starts now. Aga Khan, unmute.
Without contravening ESC anticoagulation guidance for rheumatic mitral stenosis, बीटा ब्लॉकर हर हाल में देनी है, हार्ट रेट कंट्रोल के लिए डायलिसिस आप कर सकते हो, लेकिन ये कह रहा है अवॉइड नॉन वो contravening ESC guidance सही है ना, यही लग रहा है। हाँ हाँ यही है। हाँ मेरे ख्याल में यही है। देखिए नाइट्रेट नहीं देंगे, प्रीलोड कम हो जाएगा। ऐसे आइवरमेक्टिन भी नहीं देंगे। डैप का कोई रोल नहीं है। डायरेक्ट कैल्शियम चैनल ब्लॉकर तो सेकंड लाइन है।
डी आंसर है, बाकी सब एलिमिनेट कर दो।
We'll go with E, elephant.
Okay, he has again brought the elephant into the play.
We'll go with E.
He wants me to lock E. Are you sure about it? This is the last question.
They've got too many elephants, Hamza.
So this one is a big one. So he wants me to lock this E, epsilon, elephant, whatever. Okay. For the last time in this match, I'm going to lock E. And yes! That's a correct answer. And with this, we end with a tie. I don't think we have any more questions. We have run out of questions. And both
the only thing we are left with is now a physical
physical bout. That's what we are left with.
फिर मैंने तो कहा था दोनों टीम
नॉलेज तो खत्म हो गया ना
मैडम आपकी विश पूरी हो गई दैट्स व्हाट यू विश्ड फॉर
पूरा हो गया खत्म हो गया अब इनकी कोई फिजिकल करा दे कुश्ती करा दे कुछ करा दे
Absolutely.
I think both the teams should be given some special prize, special award. They are unbeatable, wonderful teams, wonderful. I mean, very confident, very learned, and I must say that I wish I was young and I was one of the members of the team you see there. But I think I really enjoyed it. So,
very right, sir. I think we are all so proud of them. Dr. Ambar Ashraf is there. Madam, any final words from you? We have run out of words.
Thank you very much. बहुत अरसे के बाद बहुत मजा आया. Salute to all the 8 participants, their mentors and their coaches. और आप सबको भी really those who are working hard with dedication and passion, उसका आउटकम ये है. मैंने तो इसीलिए कहा था 58 पे भी देख के दोनों को जाने दें. आप 10 सवाल और भी करें तो माशाल्लाह दोनों टीमें इसी तरह विन विन सिचुएशन में रहेंगी. और ये रोल मॉडल्स है हमारे ये पीजीज माशाल्लाह. दोज हु वांट टू वर्क दे आर आउटशाइनिंग लाइक दिस. सैल्यूट टू ऑल ऑफ यू. कीप इट अप. और अगर एक जीत जाता और एक रह जाता तो तब भी मैं ये कहूंगी कि दिस इज नॉट समथिंग कि जिसे हम जीत और हार कहें. ऑलवेज इट्स अ वे टू लर्न, इम्प्रूव योरसेल्फ with this intention to apply this knowledge for our patients so that Allah Ta'ala unko sehat kamila aur shafa de. Thank you very much, Hamza, for such a wonderful moderation. Jaan aap डालते हो. Wilson Farmer, thank you very much. और इसाक साहब आपसे हम जितना सीख रहे हैं, आपकी डेडिकेशन, रोल मॉडलिंग, सैल्यूट टू यू सर. थैंक यू वेरी मच. मैंने बहुत एंजॉय किया. थैंक यू.
जैसे अंबर ने कहा ना, एक चीज तो प्रूव हो गई है कि जो लोग मेहनत करते हैं वो 100% मार्क्स ले सकते हैं. ऐसा नहीं है, क्योंकि समटाइम वी हियर फ्रॉम आवर पार्टिसिपेंट्स कि जी पेपर मुश्किल था, सिनेरियो वाज डिफिकल्ट, क्वेश्चंस आर डिफिकल्ट, बट लुक एट दिस मैच, यू सी questions were quite tricky, difficult, and they have answered all of them so nicely. मेरा ख्याल है वो एक गलती भी इनसे जानबूझ की हुई है, वरना वो भी शायद ना होती. So I think it shows that if you work hard you know everything. You can answer all the questions. So again, both the teams need excellent compliments, their mentors, their teachers, their preparation, and the teamwork. I think this tournament or this modality of learning has really made it so palatable, so enjoyable to learn and exchange. And thank you very much for your excellent moderation. All of you need to be congratulated. Hamza of Wilson Pharmaceutical needs my compliments for arranging all this and really enjoying. Thank you very much for having me and Allah Hafiz.
Thank you very much, sir, for your thoughts again. Yes, ma'am.
Thank you, Hamza. और I think so salute to all the parents जिनकी वजह से आज हम सब यहाँ पे हैं और उन्होंने इतने हार्ड टाइम के साथ ऐसा ब्रॉट अप किया हमारा कि हम हार्ड वर्क के साथ इतनी डेडिकेशन के साथ ये कर रहे हैं। तो ये जो 8 हमारे मेंबर्स हैं, प्लीज अपने पेरेंट्स को जाके जरूर कॉन्ग्रेचुलेशन हम सब के बिहाफ पे कहें। थैंक यू जी।
Thank you very much, ma'am. That's such a beautiful thought. I think we were actually running short of words, and we want to congratulate each and everyone, the two teams, Aga Khan Stars, HMC Stallions. Absolutely take a bow. I mean, brilliant, absolutely brilliant performance. I've seen many performances. I've seen 60 out of 60 performances, but I tell you today, we understand the level of questions, I mean the level of difficulty that you had, and you were going head to head, and each and every question was well read, well thought out, and beautifully executed by both the teams. I mean, you were absolutely at par, and this is one of the best performances, I think, which will go a long way. And congratulations to you, to your mentors, to your coaches, and most of all to your institutes, and most of all, even more than that, your parents. And brilliant performance all around. And I hope I can have both the teams in front of me. I just want to take a look at them one more time. Can you bring them on the screen? Well done, Stallions. I can see you. You ran like Stallions, and best of luck. I think now it's a tie, and the team is going to work out. And eventually, I think it's going to fall on the run rates, and eventually one of you, or maybe, you both will end up somewhere. But, brilliant. Keep it up. Very well done. And I would like to say the same thing. Can I have Aga Khan Stars on the screen? So I think they've left, but I think this can be communicated to them, conveyed to them. I hope they'll be able to see me. Salute to Aga Khan as well. Brilliant performance all around. And I think Wilson Pharmaceutical, Hamza, and the whole team which is involved in this is something which everyone needs to be credited for. It's a wonderful performance, and a lot of effort goes into it. And I am absolutely feeling honored and privileged to be a part of this league and this team. So once again, with this excitement, we all have to go home, and I think we are going on a brilliant high. So thank you very much. Till next time, it's going to be Allah Hafiz from our side. Take care of yourselves.